Hello and welcome to Living With, a brand new program here at Fellowship Health Resources, and we are incredibly excited to be bringing you this brand new programming. Today we're going to start the discussion with Obsessive Compulsive Disorder, otherwise known in some circles as OCD, and we're very happy to have with us Stephen, who is our person living with, and Dave Richardson, who is the lead clinician from our mobile treatment team in southeastern Massachusetts. Gentlemen, it's so good to have you here.
Thank you. Thanks for
really
having
good. And they're all important discussions because as we move along in the series, we're going to learn so many different things with so many different people living with, as we say. But I'd like to just start by saying, what is, in layperson's terms, obsessive compulsive disorder? Dave?
Well, obsessive compulsive disorder, OCD, is an anxiety disorder, and I think people have sort of a stereotypic image of the compulsive hand washer, and I think OCD is a term that's used often in just everyday language, sometimes in a humorous context, but it can be a very serious disorder. It's characterized by intrusive, repetitive, obsessive thoughts and compulsions, which are behaviors that a person feels obviously compelled to do and feels as though they're impossible to resist. So.
Hey, Stephen, I would just ask you to bring us into your world a little bit. This is something that you live with day to day, and when did you start feeling this?
I have been dealing with OCD since I've been a child. Not as bad as, as I deal with it as an adult, but it started off when I was a kid. My stepmom would say, you're saving things, you're holding on to things, you're collecting things, and she would actually dump out my drawer and go through it and say, you don't need this, you don't need that, and things would get discarded. But then as an adult, after some trauma, it actually started occurring again, and I started with some kind of rituals of hand washing and checking and stuff like that. And one of the things with OCD is there's another component to it that a lot of people actually don't know about till recently, because it's actually just come out, and it's been prevalent in the news lately. It's hoarding, and I have a problem with hoarding, collecting items, and being unable to discard them. And I'm actually working in the past 3 or 4 years on some kind of cognitive behavioral therapy and exposure response therapy that is new to people with OCD and other disorders to get rid of this stuff. And I've been working with Dave and the peer specialist to actually discard stuff, and I've been doing real good at that. So, and I'll let Dave talk about more what he's doing to help me with that. But OCD is a real tough disorder, and it'll eat you alive if you let it. And
And Dave, I think from a clinical perspective, this is not a one-size-fits-all sort of thing, right? There are varying degrees, and as Stephen was saying, from the hoarding to the repetitive kinds of things, and this is something that has to be almost, just you have to approach this differently for different people, don't you?
Right. There's probably an OCD continuum, and there are lots of people who don't have a diagnosis who have some degree of OCD and have some of those patterns and some of those thoughts. And you probably would definitely run in families if you took a family history. And even in Steve's case, you can see that he has relatives who had traits of OCD. So in order to be diagnosed with OCD, it involves more extensive periods of time that a person's engaging in either the obsessive thinking or the actual compulsive behavior.
There may be families out there watching right now that perhaps have been thinking that something may be off. Okay, so if you have a child who is perhaps dealing with this at a young age, can't quite figure it out, something's a little bit amiss, something is definitely off. Are there signs, are there patterns, are there things early on from when you can think back as a child or perhaps an adolescent that you had to be dealing with some of these things that could help people right now? That
Right.
Is early intervention a good thing
I think,
to be paying attention
you know,
to?
I think it's a catch-22 in the sense that you want to address those behaviors if you see them. At the same time, it's important not to pathologize because I think people with OCD are very perceptive.
Yeah.
And there's a part of a person with OCD that really understands that maybe the obsessive thoughts aren't quite realistic or may not be 100%, accurate. So there's a dilemma for a lot of people with OCD. They tend to kind of conceal their obsessive thoughts, or they may engage in their compulsive behaviors in private. So they may not always be readily observable, unless you're trained in it or unless you kind of know somebody that has OCD.
Stephen, how difficult is that for you? Because I imagine, as you said earlier, this thing can eat you up, right? If you
Yes.
if you let it, or does this thing just become such a big part of your daily life that you're dealing with it as best you can?
Yes, it can become overwhelming, and like I said, it just, there's so many different things to it, so many different aspects to it. You're making mental lists, you're checking, and you're just out there, and you're just struggling with it, and it's hard to explain to somebody what you're going through inside of your mind. And
give us an example. Give us an example. If you can give us a
specific examples, is you're walking down the street and you see something on the ground and you're like, would I need that piece of literature or something like that? Collecting things, going into a book sale and collecting a lot of books, or that you might read them as a hoarder, collecting magazines, and upon magazines where one person would collect 2 or 3, where in a certain day's time I would collect dozens upon dozens, and in a month I could buy hundreds of books. And I can remember washing my hands to where they would become raw, and showering for 4 hours, going from showering to from 4 hours to not showering at all, in different phases of it, where it waxes and wanes, and that terminology means going from one extreme to the other. And it's just so disabling, having to remember numbers, making mental lists inside of your mind. And there's just so many things with OCD. It's just you don't know what to do. You're just trapped inside of your mind. You keep calling people for reassurances. Is everything going to be unbelievable thoughts? You need reassurance of things, and washing things over and over again, fear of germs, contamination,
all the things
like
that you hear of all the time,
and
you can read about this stuff,
yes,
and you can
yes,
see it, but
yes,
you're living it.
Yes,
you are really truly
yes,
living this, and have been
yes,
for a long time. I'm just curious, Dave, how long have you been working together, and what are some of the concrete things that you do to help Stephen?
Mm-hmm. Well, Steve and I actually worked together several years ago, and then recently we started working together again, maybe about 4 months ago or so. Mm-hmm. So we had done some work on OCD during that time period, and now we're kind of doing some follow-up work, and it's nice to come back and see that he's made some progress. One of the things that people with OCD face is kind of a dilemma, or a catch-22, in the sense that when a person has intrusive obsessive thoughts, it's a response to anxiety, and there's a natural tendency to want to engage in that compulsive behavior, because the compulsive behavior actually reduces the anxiety, but what it also does is it reinforces that pattern, and the pattern becomes more and more powerful and ingrained. So one of the specific ways we try to help Steve is we try to help him identify when he's having an obsessive thought. We can actually relabel it as being an OCD symptom, and then also trying to resist the compulsion and actually block the response.
Is it common for someone living with OCD to have sort of a dual disorder? Does that sometimes play a part?
Yes, co-occurring disorders
Yes.
can happen. I also suffer from depression and post-traumatic stress disorder from other things that have gone on in my life, and it can make it like having a double heaping of something. It's very, very tough. But I also want to offer people hope. There's so much things as what Dave offers me.
Sure.
And the team that he works with, hope. And also, I've been on numerous amounts of medications. Right now, I'm taking a medication, an SSRI Paxil, in a very high dose for OCD, and it seems to be working very well, not only for the compulsions and rituals, but for the hoarding, and it works very well. So I have made so much progress since I worked with Dave 5 years ago, and there is hope, and things are getting better for people with OCD. And it's a battle. It's a everyday battle, but it's and the best thing you can do is just keep fighting along with it and working with your treatment team or your doctor, and you can get out there, and there's a lot of help out there offer. And I would say to people, read up, go on the internet, ask questions, go to support groups, and stay involved.
And that's really the message we're trying to get across here today, is that there is hope. You can be having severe symptoms as you have, but thanks to the services of Fellowship Health Resources and what all the wonderful people in the organization are doing every single day to help folks like you, that's what it's all about. It's all about hope. And a part of that hope is peer recovery, peer specialists that we have in our wonderful organization. That's what we're going to focus on in the next segment. And we've got Bob Russo coming up. So we will explore all those things in the next segment. But gentlemen, we're thrilled that you're here again. And this is really important stuff to get out to people, that they understand what it is that you're dealing with every day. We'll be right back. Welcome back. We are joined now by Bob Russo, who is a certified peer specialist from Massachusetts and a good friend of Stephen. Bob, welcome. It's great to have you here.
Thank you, Mike. Good to be here.
The first question I have for you is, what are some of the things that you guys discuss? We've heard what Stephen is dealing with all the time. It's not easy, Bob. You can feel that. You can relate to it. You can understand it. On some levels. Nobody can walk in his shoes, of course, but when you hear his stories, when you feel some of the anxiety, what are some of the things that you can do to help him?
Well, I think because I live as well with a psychiatric disorder, that Stephen and I are able to relate with each other from a common ground. And so I know some of the things that have helped me live with my illness and helped me to recover. So I can make suggestions, to Stephen, and we can we can act on together. And some of those have included, that one of the things that Stephen, had to deal with a lot is boredom and loneliness, because it's very, as he shared earlier, it's very difficult, living with the obsessive thoughts and the list making, and you can become very tired and very concerned, and you don't really want to socialize much. So one of the things that I really encouraged Stephen to do was to get involved in various kinds of activities, and I started a recovery discussion group, and Stephen has been a faithful member and contributor of that group, where he is able to talk about what's going on in his life and listen to other people who are living with a variety of mental disorders, talk about their experience, and we can come up with an ability to help each other and empower each other, to live with this in a better way and to work on our own recovery.
How does he help you?
Oh, I just can't say the way. There's so many, yeah, there's so many ways. As somebody who's a peer specialist and who's living with has the lived experience that he has, that it's going through things, and I can bounce things off of him and say, have you ever had that before? What should I do, you know? And it's just, he's such a resource. Mm-hmm. He's such a gem, you know, and it's just, you know, the whole blooming field of peer specialists and everything, it's just, they're so good for people with psychiatric disorders. And Bob's able to help me just with my own diagnosis, not only with the OCD, with the depression, and with things like organizing my apartment and going through and discarding things, and he's just able to be a lifeline, someone to call when I'm in a stressful situation, and
put it all together.
Put it all together.
Right.
Put it all together.
How long have you two been working together?
Oh, I would say almost 4 years now.
Yeah, going on.
Yeah.
Wow.
Going on 4 or 5 years.
Actually,
yeah.
Stephen remembers, just happened to be in the office the day that I got hired as a peer specialist.
Yes, I
he
remember.
actually saw
That was an
me
exciting time, huh?
handing in my paperwork to who was the team leader at the time. And so actually Stephen met me my first day at work, working for fellowship as a peer specialist. And
yeah.
And we've had many wonderful adventures together in recovery and working on our joint recovery. And specifically, as you can see, Stephen has really got a tremendous ability to speak and to use words well and properly, and is very clear in his thought. So I thought, gee, wouldn't it be great to take Stephen to Boston, to the State House, to do some advocacy work on legislation affecting people with mental disorders? And we did. We took the train and we went to the State House and we saw our congressman and we made appointments. And it was particularly about how what I think is a very inhumane treating of persons with mental disabilities by the use of restraints. And so there was a bill in the legislature to stop using physical restraints and to find other ways to de-escalate situations when people are having difficulty, so that their rights aren't violated in the process. So Stephen actually shared, his experience of what that horrible thing is like when you're put in restraints, and was then able to, help people understand, why these laws need to be in place to help protect people.
Well, it's critically important too that these decision makers, these legislators, hear from the voice themselves, to hear from the person who is living with. Correct?
Yes.
The name of the program says it all.
Right.
This is the person who is living with. And life experience. We're not just talking about something that you read. This is something that you can look at them square in the eyes and say, listen, this is important. It's important that you hear me as well.
Yes.
Correct?
Exactly. And living with OCD and going back to, living with it for, the past 26 years. And, the trials of medications I've been on, the therapies, the therapists, the hospitalizations, and how far I've come in that time, the progress I've made. Someday myself wanting to maybe work in the field doing something. It's even going back to when I first met Bob, I was skeptical about him, being a peer specialist. What are they going to do for the peers? What are they going to do? I wasn't doing as well, but I'm so optimistic about the future, and the movement and the people with OCD. There's so many, like I said in the last segment with Dave, there's so many opportunities. There's the medication, the therapies, like I said before, you know, and it's just so, it's good.
Stephen,
it's
before
good.
we move to the next segment, I just want to ask you briefly, if you can, what Fellowship Health Resources has meant to your life?
For the past, I would say, 17 years, they have meant stability. They have meant, I know they're not supposed to be friends, but they've been like therapeutic friendship
Yep.
to me, and they have kept me out of the hospital. Sometimes I've had to go to the hospital, but they have been like
A guiding light, a guiding force.
a guiding force, and you know, they have lived up to everything that they said they were going to do to help me in my recovery. You know, help me in my recovery and what I wanted to achieve, and you know, and I'm doing very good. And I've been through a lot, but you know, I'm still going through a lot. But you know, it's just like in their motto, you know, they do what they supposed
say.
to do.
And you are living proof that all of this is working. And
Yes.
in the next segment, I want to get to, you know, how the peer support and the clinical come together to help you. But Stephen, thank you so much for coming in, and we really appreciate you telling your story.
Thank you.
And we will bring in Dave in the next segment, and we'll talk about that. Be right back. Welcome back, and we are joined again by Dave Richardson, and you heard the conversation going on between Bob and Stephen, and I'm just curious from both of you's point of view, that perspective, how do you tie all of this support together? Dave?
Well, I think psychiatric diagnoses can be very alienating, and one of the nice things about having a team, and in particular having a peer specialist on the team, is that we are kind of pulling together the therapeutic relationships and the peer relationships, and we're connecting people more to the community, and kind of developing more of a feeling of inclusion as opposed to exclusion. And I think that's probably one of the most meaningful things that we can do as a team. You know, on our team we have people with different disciplines and different backgrounds. We have nursing staff, we have a housing specialist, you know, we have a psychiatrist, so we all have different perspectives and different training backgrounds, but I think the peer perspective is really the critical piece, you know, the critical spoke in the wheel.
Do you guys meet? Do you talk? Do you have discussions? Are there sort of group meetings? How does this all work, Bob?
Well, there are team meetings every morning, so that each person on the team, each specialist, comes together and review how the particular person is doing, and support each other, because we have common goals. You know, what we're hoping is to help each person that we serve further integrate into the life of the community. We want to help them increase their personal responsibility. We want them to have a deeper insight and understanding of what their illness is, so that they can increase their own commitment to their own recovery. And so really we're all working to empower them. We're all working to bring them hope and to bring them a better future. And so we work collaboratively to try to make that happen.
You know, it was interesting listening to Stephen tell his story. This has not been easy for him.
No.
But
No.
he is doing very well. You can just tell that, you know, and as he mentioned, between the combination of medication and support and peer and all of the clinical that goes into it that you guys have done so well with, he is living a life where he can find happiness and comfort. And I think that's really, as everyone believes, it is about building that hope so that someone can live a good life, isn't it?
Absolutely, yeah.
A couple of the things that Stephen is presently doing, you know, that is so hopeful and such a positive sign, is he has a volunteer job, and he goes several days a week, and he works in a pet store, or actually it's really like a place where people can come, to adopt a dog, to adopt a cat, and he spends a lot of time, caring for the animals, and it's great because it gives him a sense of purpose, and it's really doing something positive. And Stephen, another thing that he does that I think is so good is he really educates himself well about his illness, about the medications that are available. So he takes a lot of positive signs. He's involved, and I've seen him in the last couple of years, become more connected with other people in relationships. And that has been wonderful. He's connected with other peers. They've gone out and done things together. They've had lunch together. And all of that, really has brought a greater sense of fulfillment and direction, for his recovery. So it's great to see that.
So much of this is what he's living with is sort of layered upon layers of anxiety, I think. Correct me if I'm wrong. But I think that's a big part of it. And so when you bring in elements like this, where he's in an environment which brings calmness and that sort of a soothing feel, that plays a big part in the recovery.
Right, and I think, one of the nice things about being on a psychiatric outreach team is we're actually helping individuals change their environment. So we are literally, in a person's living space, helping them figure out how to make it feel safer for them and how to make it feel more comfortable. So they feel, more in control of their lives, and there's more of a sense of autonomy.
This is well thought out therapy, isn't it? You guys, we know Fellowship Health Resources takes this very seriously. The clinicians, the peer support, from top to bottom, this is what we do here.
Right.
And so for people to just understand that this isn't just an ongoing experiment. This is proven, tested stuff going on here, isn't it?
I think the most important thing is just to have an awareness of the relationship itself, and I think that sometimes people forget that the biggest tool that we have to help people is the relationship and our own humanity that we kind of bring into the picture. And there's a theory that a very valuable process that goes on in therapy is the emotionally corrective experience. So if a person can have a fulfilling, positive relationship with a peer or with a therapist, and it's rewarding and it validates their worth as a human being, that in itself is very therapeutic, and to some extent that's a natural process that you're kind of trying to steer, but it's less about the specific intervention or brilliant skill, right? What do you think?
Do you tailor your approach to it, this, Bob?
Yes, I think that what David just said is so important, because what I've been trying to do is to help everybody on our team understand that what we have are people to be understood, persons to be respected and be understood first, and not just the pathology to be treated. It's important that we help people identify their symptoms, understand their disease, work towards, resolutions, but as Dave just said, the relationship, having to receive a person, to respect them, to understand that it's their recovery, that they're the ones who are responsible for their recovery. We're there to assist, to support, to help, and to empower. But to really, and I think that's what fellowship, at least my experience, has done so well, is to always keep, the person, to have his person-centered.
PRISM model, right? It plays right into
model.
what fellowship, that's the core of it all right there, isn't it?
That's it.
Is there a final goal of recovery? And I know that there is no sort of finite answer to this. It's ongoing, but again, as we said earlier, it's about finding that good place, that happy place, that place that people can get to.
I mean, tragically, a lot of people live with chronic suicidal thoughts because their lives are so difficult and they struggle with depression or symptoms or psychosis. So I think one of our goals is to help people build a life that's worth living. So when they get up every morning, they say, my life is worth living, and they are transcending some of the challenges that they face. And for lots of people, their lives are going to be difficult. They're going to be facing challenges, and they're going to have their good days and their bad days. But for them to say, my life is worth living, I've grown, I'm making progress, I'm going to grow more in the future, it's probably what we're working toward.
But knowing that that help is always there, right?
Right. And that recovery, is real, that it happens, that people get better, they get well, they're able to get employed, they're able to work, full-time, and even get off of disability and start contributing positively, to the society. So it's really a wonderful time to be in this whole area of work, because some very new and positive things are taking place.
Well, we're really thrilled to have this series underway, and I just want to thank you guys again for your contributions and your dedication to this organization. And I think as we go forward here, we will continue to hear these wonderful stories. We'll hear challenges, but we'll hear tremendous stories of recovery of all the people that this organization continues to help on a day-to-day basis. So thanks again, and we're looking forward to moving on with other things going forward. All right, gentlemen.
And thank you.
And we look forward to seeing you next time on the Living With series. Thanks so much for joining us. We'll see you next time.